speaker is Allana LeBlanc. Allana is a clinical nurse specialist in intensive care and High Acuity Unit at Vancouver General Hospital. After completing her nursing training at Dalhousie University in Halifax, she moved to Vancouver, where she worked in neurosciences and intensive care. She completed her graduate studies at University of Ottawa. She has a passion for critical care nursing and for improving quality patient care. Please join me in welcoming Allana and her presentation, ICU Views from VGH.
Thanks, Emily. Okay. Thanks, guys, for inviting me to talk about one of my great loves, is intensive care and high acuity. As Emily said, I've been in the ICU for a long time. 2005 is when I started in ICU at Vancouver General. And I did a few things in the meanwhile, but I always came back to the ICU and then have been in the clinical nurse specialist role for the last 3 years and started around the same time that Vinny started at St. Paul. So it's been nice to have a buddy to be able to bounce ideas off of. So the objectives of my talk today are to just to give an introduction to VGH, ICU, and HAU, talk about the nursing that happens there, and some recent challenges and successes. So everyone so far has given a lot of data and a lot of facts and figures, and I'm happy to answer questions about facts and figures for what I have. I put in a few data points into my presentation, but for the most part, I want to keep it a little lighter and just talk about, what we do with the day in the life kind of thing. Sort of give you the story of what I think of the ICU, and anybody online, if they want to, or in the room wants to add stuff, please feel free. And feel free to interrupt me with questions or anything like that. I'm happy to keep it as informal as we can. So most of you know, this is VGH. It is a big building and two big buildings. There are 780 beds at least in the two towers. The ICU, the intensive care unit, and the high acuity unit can get referrals from pretty much anywhere within that hospital. But there's quite a lot of diversity, and that's something that will come up a few times in my talk. Sometimes there's a bit of confusion about what's in the ICU, what's not in the ICU, what's different, what other units are available for critical care, because it's quite a diverse group. So in the ICU, all of the nurses are critical care trained. They either have CCIP or some equivalent training. In the HAU, the nurses there have a high acuity course or some equivalent training. It's an adult intensive care. In VGH, we have several other units that are sometimes classified as critical care, sometimes not. Some people do get them mixed up with what is in the ICU and what's in the HAU. So the ICU is ICU and HAU. We are not the coronary care unit. We're not the cardiac surgery ICU. We're not the post-anesthetic recovery unit. UBC has a surgical observation unit, which sometimes gets mixed up with HAU and other sites. So our HAU is not a surgical observation unit. There's a separate spine ICU, which is not a critical care unit, even though it's called an ICU. So that's not us. We're not the neuro ICU, which is another specialized unit that isn't the ICU, not run by intensivists. And there's a whole bunch of other step-down units in VGH. We are not peds, but a couple weeks ago we had a 14-year-old patient, and we get referrals from all of these places depending on what their needs are. So we could get patients from any of these units. It's a very, like I said, we're sort of this catch-all. And I don't think that's very different across different sites. I think it's just that we have a lot of, because it's a big organization, we have a lot of sort of, it's hard to drill down sometimes exactly what the layers are. These are the sort of official numbers. Vancouver General ICU has 32 funded beds. Many of you who've been there or heard us talk about it kind of laugh at that number, because we all know that VGH ICU is chronically overflowing, which is also the case. I'm not saying that we're the only ones. Yeah, we're chronically overflowing. We have 1,600 roughly admissions per year. There are more than 240 nurses who work in the intensive care unit. We have ADRTs that circulate through the intensive care unit. Every day there are 3 physician teams that round on these patients. Each of those physician teams has one intensivist, usually a fellow, many residents and trainees. They also have a dedicated dietitian and 1 pharmacist per team. We have physiotherapists that are there 7 days a week, occupational therapists that are there 5 days a week, social work, and all the other allied health that you can think of. It's a lot of people. I put a lot of pictures in here. I really want to showcase the great work that happens. Canadian Intensive Care Week last October, was it? We had a CACCN event, but at VGH we chose to celebrate the whole whole interprofessional team. So we had a bunch of events. There was events every day. A lot of people contributed to making that happen. So one of the things we're trying to embrace at VGH and the ICU and HAU is trying to celebrate our successes, celebrate one another, and create a positive working environment for, our work is hard enough. We don't need to make it any harder than it has to be. So just try to create a positive working environment. So day-to-day life in the ICU, we have more than 30 nurses per shift, assuming we can fill all of those. A lot of times we can. A lot of times we're relying on overtime. That's kind of our minimum. When we do have overflow, we will often attempt to staff up to staff the overflow as well. So we don't always make 30, but that's kind of what we're shooting for most of the time. The vast majority of patients are 1-to-1 ratio. I put in 2 doubles there, and you even saw on Steve's scorecard the doubles, the average doubles. And so I don't know about the rest of the sites in BC, but doubles are a great deal. There's a lot of talk about doubles at VGH ICU. We spent a lot of time talking about that. A few years ago, we went through a change where for many years we had been shooting for like 3 to 4 doubles. And as the patient's acuity and complexity grew and the more overflow, that sort of migrated up to, if you shoot for 2, you get 3 or 4. If you shoot for 3 or 4, you're getting 5 or 6. To find 12 patients that are appropriate to double is not easy. So this was contributing to a lot of dissatisfaction and led to moral distress where nurses were going home feeling that they couldn't give safe care for their patients. It was leading to problems where charge nurses were going home feeling like they were punishing their colleagues for giving them a bad assignment. It wasn't a good place for us to be, and so I have to credit Jackson Lamb and George Isaac, the manager and the medical director, for really opening up the conversation with the PCCs, the leadership, and the bedside nurses as well as the charge nurses, and saying, okay, well, what are we going to actually do about this? And loud and clear, people were saying, it's not just about the acuity, it's not just about the difficulty of caring for these patients, it's really about the doubles. We hate the doubles, it's so hard. So they supported the informatics nurses to assist us to do a workload. Vinny was a big part of this, to analyze the workload in the unit and to really look at what are other options and what realistically should we be shooting for if we could have everything we wanted. And of course, if we could have everything we wanted, we would want no doubles. But we settled on those 2 doubles. And that's what we shoot for. And I'm proud to say that for the most part, that's what we do on average. Doesn't mean that there aren't shifts that have 3 or 4, but most of the time we have about 2, and sometimes we have none. And so it has made, I think, of all of the changes that have happened over the last number of years, I really do think that this is the biggest impact. So I think that should be acknowledged. We have 3 physician teams. Allied Health, all Allied Health are Monday to Friday. The Tuesdays are 7 days a week, but there is reduced availability on the weekends. Nursing leadership, we have 1 manager, Jackson. We have 3 clinical nurse educators, Simmons is, I believe, still on the line. We have 2 PCCs, or CNLs, as I think they're called, at Providence, so regular charge nurses, 1 CNS, that's me. Other nursing leadership positions, we actually have a partial, as part of their FTE, is a code blue coordinator and a CCOC coordinator. So it's not a full-time FTE. For the HAU, it's a separate unit. We're still learning a lot about HAU at VGH. Started up in 2015. It has 12 funded beds. We see about 950 admissions per year. They are all admitted by the intensivist. There are about 80 RNs that work in that unit. They are, like I said, high acuity trained. The intensivists admit these patients, and so each intensivist team has patients shared between the ICU and the HAU, which leads to some confusion as to where they are, and it's a big unit, and trying to track people down, it was always hard, and now it's even harder. But that's how it seems to work best for the workload from the physician side. And so the pharmacist and the dietitian is associated with that team, and then the other allied health are spread out in different ways. And the HAU beds are physically located in the burns trauma high acuity unit. So those nurses, those 80 nurses, have specialty training in high acuity, but they also take care of all the high acuity traumas that are not ICU patients, not managed by an intensivist, and they take care of all of the burns, whether or not they're high acuity or not. So they have a really diverse skill set, and high acuity actually is only part of that. So it's a really special group. It's a picture of actually the whole shebang, because some of our ICU overflow beds are actually pictured here in the background, and that's trauma rounds, and that's actually physically located in the burns trauma high acuity unit. I've listed most of the pictures I've listed from the internet. This was an ad for burn camp, but this is one of our nurses. For staffing for the HAU, there's 10 10 RNs per shift, the 2-to-1 ratio, because it's not just the HAU beds, it's also the trauma and the occasionally it's 1-to-1. We've selected out specific populations that may need a 1-to-1 ratio. So that would be the one that's really common is we sometimes for pulmonary embolism will have catheter directed TPA. So the catheter is basically a PA line that's set up by the interventional radiologist and TPA right there. So we've made those patients 1-to-1 because we don't want those catheters to move and we want them to get all of the appropriate attention. And then occasionally there are 3-to-1 assignments as well when we have a lot of ward patients. Similar setup, all the allied health is Monday to Friday, and the physio is 7 days a week. And because of the burns and the trauma population, particularly the burns population, there are physios and their OTs across both populations, and so they have a slightly different ratio in terms of patient load. In terms of their nursing leadership, there's a different manager. Her name's Susie. They have 1 clinical nurse educator, 2 PCCs or CNLs, 1 CNS, that's me. And they also have nursing leads in the burns and the trauma program. So we all try to work together. I'd have to say that we enjoy great relationships with the other programs. At the nursing level, we really work very well together. I think we improve things together. So I want to spend some time talking about patients. VGH serves a number of specialty populations. This is an example of the neurocritical care population. So this is Mike. He has a brain bolt. Some of you have seen these in your own practice. The brain bolts allow us to tailor therapy for and reduce secondary injury for traumatic brain injury patients and some other neurologic conditions. This evolution has happened. Simi and I actually presented this at Dynamics last year about the evolution of neurocritical care at Vancouver General. This has been a long but very fruitful project of basically upskilling everybody involved and then just continuing to build on successes to provide this really highly specialized care. And it's involved partnering across, like between the intensive care and the neurosurgical service, but also a lot of positive building within the nursing team and then within the RT team. And this is work that's still ongoing to perfect it. And this is why we do it. So this is also Mike, less than a year after his injury. And this is what we're hoping for, right? The guy who got smacked by a car and his bike. All of these patient stories and that are part of a project that our attorney has been spearheading. And so either the pictures are either from the Patient Stories Project or from like the VGH website or something. So that's Mike. He's also a personal friend of one of the nurses that used to work in the ICU. So he's very generous to share his story. But he's doing well. He's back at work. So what are the patient populations that we see in the ICU? Well, we obviously have a large proportion of medical surgical populations. We have neuro and spine, so that's regular neurosurgery as well as the neurocritical care piece. We have a spine service that's specialized for traumatic spinal cord injury and other reconstructive things. So some of those patients, if they need additional ventilation or they acutely deteriorate, often are cared for in the ICU for a time. Then they may go to the spine ICU that told is not us, and they can actually do mechanical ventilation, and that's for those patients who need continuous mechanical ventilation. But yeah, so we work very closely with them. We have the trauma service, we have the burn service, we see all the liver and lung transplants in BC. We do also, the VGH also does some renal transplants, not as many as St. Paul's, but we rarely see those patients in the ICU, but we often see them if they're having a bit of instability after their surgery. We often see them in the High Acuity Unit. And finally, there's been a lot of discussion in BC around extracorporeal life support, ECLS or ECMO. And so the guy on the left here is Lily Daligan. He sort of hit 2 specialty populations because he came in with his terrible deteriorating intrapulmonary fibrosis, idiopathic pulmonary fibrosis, and put onto ECMO, got his transplant, and is doing very well. So here's my stat slide. It doesn't have any good graphs on it, but I put a picture of one of our patients. So that's Cody. He was another traumatic brain injury, benefited, we think, from the neurocritical care approach, and has had a really remarkably good outcome with his parents. So a little bit of like vital statistics of the patients. The majority of our patients come from emergency, about 40%. A little bit less than that come from the OR, and a little bit less than that come from the wards. Our median length of stay is 4, and as Steve talked about, we've been tracking median more recently. But if we look at the average, which is what Cindy presented earlier, it's about the same, about 7 days. Mortality in the ICU, this is a question that we get. I don't know about you guys, but when I trained, I was told that all the ICU patients die. It's terribly high mortality, and that's kind of what I was expecting, and that doesn't really pan out, actually, and the number's not now anyway. Mortality in our ICU is under 18%, fluctuates obviously some. I just pulled these numbers from the dashboard yesterday, and hospital mortality for ICU patients only slightly higher at just under 24%. Our ED to ICU transit times are 5 to 6 hours, and we think that's too long. But we think that is mostly due to something else I'm going to talk about, which is our ICU overcapacity. Because we know when we dove down, took a better close look at the data, we realized that the ICU consults were happening fairly quickly, but then there was a delay in getting them in, and that's usually because a lot of our beds are full. So I put these two pictures side by side because, this is kind of like what VGH thinks we do all the time, but we do this too, right? So we have a variety of patient acuity, and all of this is important. So Vinny worked with me at bedside for a long time. She knows I'm happiest when I'm lost in all of the technology, and I love that stuff. And that's one of the reasons I gravitated towards an ICU environment. I have to say that later in my career, I started to really get the energy from patients that look more like this, who is somebody who's awake and smiling and mobilizing and not sedated and still ventilated, and yet getting better. And we've learned in the last number of years that in spite of the acuity and the complexity of our patients, that actually most of them tolerate being awake just fine. And there's a lot of benefits to doing it that way, we know from the literature. But then on a personal level, as a nurse, there's a lot of benefit to engaging with those patients as well. So I think we need to embrace all of the things that we do as ICU nurses, and it's all important. Patients in the HAU are slightly different. They don't see as many of the specialty populations. Because we have a neuro ICU and we have a spine ICU, patients who are transitioning out of the ICU will often go to those specialty areas, but not exclusively. And so they do see a variety of patients there. Most of their admits come from the emergency department or the wards. A lot of those are patients that would be seen by CACCN and then come down. So there's a lot of these other patients that are admitted to the HAU from the wards are the patients that Vinny's talking about that CACCN is seeing out there that have been already admitted and they have this long hospital stay. All right, the average length of stay in that high acuity unit is 2 days. So what that means is 12 beds, 2 day length of stay. These people are admitting all day, all night, all the time. They're absolute masters of admitting patients. So the workload there is very high, and so it's got a picture of the team, because if it wasn't for the team, nobody would work there. It's really a lot of workload. The patients are interesting, and there's a lot of diversity, and there's a lot of skills and enjoyment that way, but the workload is high, and so they really pull together to really give good quality care to patients, and I'm very proud of being able to work with them. Mortality in the HAU is expectedly much less. But their hospital mortality, the difference between their mortality in the unit, only 2 day length of stay, and the hospital mortality is greater. So those patients are ill, they're sort of looking kind of peaked on the ward, they get taken to the HAU for a few days, tuned up, and gone back out, and the larger proportion of them actually die outside. Hopefully they're not precipitously dropping, which is why, when we bring patients from the wards, they often die within our walls because they're requiring high levels of life support. Guys can probably return to the wards of safety. The emerge to HAU transit time is 9 to 10 hours. We also think that's too long. We think the reason for that is these are really the gray zone patients. So they come in, they're consulted to medicine, they may get a liter or two, they get their lactate measured, they're still in emerge, they're in acceptance transfer, and then ultimately they are consulted to HAU. So we think that that's the process that's happening that is slowing down that process too. The actual time to the actual consult is a little bit longer because ideally, an emerge physician or emerge nurse, as soon as an ICU patient rolls in the door, they're like, yep, call the ICU. You don't even wheel them into the bay before they've consulted the ICU. Where these patients are a little bit more complicated, they're a little bit more gray zone, so there's a little more discussion that has to happen before their disposition is decided. This is the patient's eye view. This is part of the CPR challenge that was part of our celebrations of Canadian Intensive Care Week, so I thought that was super fun. There is a difference. Working in both units, there is a difference, and I kind of didn't expect that. I had to say, I thought, the ICU was the king in teamwork. We are good at teamwork, but we also like to be the lone wolf in my domain. Thou shalt not touch my patient. It is a distinct way of practicing, and that's been a real learning for me as we've gone down this road, and things that happen in VGH project work and ideas that we've tried to bring to fruition that come directly from bedside staff. That's something we've been working on very hard over the last number of years. So sometimes I forget all that we've been up to, but I thought I'd highlight a few things anyway. Early mobilization is something we've been working on for 5-6 years now. We implemented a pathway that we borrowed from St. Paul's, and Steve talked about how we want to bring it into the database and how we want to maybe create one of those dashboard bands to examine it. But the bottom line is that a lot of mobilization happens, and this is an ongoing project where we most recently have revisited it. We knew we had changed practice, about 5 years ago, kept people more awake when we're doing more mobilization, but a lot of it was physio-led. And so there's a difference between physiotherapy and mobilization. I think we had lumped those two things in together, and as a result of that, patients were waiting to be mobilized until physio could get there. And so we asked ourselves, well, even nurses even told me a couple times, they're like, well, I have to ask the physiotherapist. And I was like, excuse me, you have to ask who? In nursing, we're fully capable of figuring out whether or not a patient can be mobilized. We're not physiotherapists. We're not going to be giving therapy necessarily, or not going to be prescribing physical therapy, but we can certainly make an intelligent judgment as to whether or not this patient is going to tolerate sitting up, whether or not this patient is going to be able to be mobilized out of bed. And if you need additional advice, we've created a screen for patients that should be flagged for additional advice. So basically, if it's your run-of-the-mill pneumonia patient who's had their couple days of antibiotics and they're coming down on the levo and they were walking and talking 2 days ago before they came in, well, that's probably the patient that we can probably safely mobilize. So there is a lot more nurse-led mobilization in the ICU now. I'm really proud to report that. And one of the benefits of that from the nursing staff is that it allows them to manage their workload a little bit easier, so they're not waiting for somebody to come by. They're just like, I'm going to pop them in the wheelchair and then physio's going to see them later. So that's happening with ventilated patients. That's happening with patients on CRRT. Our documentation rates aren't the greatest for mobilization, and so we are really wanting to optimize that and figure out how we can do that. But one of the things we need to do is to optimize our documentation. So stay tuned. Patient storage project created by Lara Gurney. That's Mike again. That's the same guy that was walking the dog earlier. It's a way to collect images and stories of patients who've passed through our walls and be able to feed that back to the bedside staff. I love this project. I'm really happy that I was able to help out with it. Lara's doing her master's on it. She's going to be doing some qualitative research. And so she just won the Sharon Stapleton Award. Okay, so not everything is perfect. Have you ever seen this, but with a garbage can underneath it? I like how people have taken out, they've analyzed their script, right? But then they just left it there and then So sometimes things don't go as we plan. So what are some of the challenges in both the ICU and the HAU? We have a massive amount of staff. Trying to send one single message to 250 people is really hard. There's only 7 people in the leadership. Sometimes I feel like I'm repeating myself, and I know that this is the case everywhere, but sometimes I've said the same thing so often that I'm kind of surprised that this person hasn't heard it. And so I don't blame anybody for that. It's a fact of diffusion of information. And so this is something I really had to learn coming into this role, was that, spoken words vanish into the ether. So it's actually it's a really inefficient way of communicating. It's great to have FaceTime and all that stuff, but there has to be other alternatives. And so a lot of what we've been working on, and certainly the CNEs lead a lot of this work, is developing resources for bedside staff that are actually easily accessible. And the form of a laminated sheet, or it might take the form of loading in documents up on the team site and trying to reduce barriers to information as much as possible. This ongoing work is difficult. Sometimes we're more successful than others. The neurocritical care pieces have come together really nicely. And so that's been one of the models that we've been looking at going forward, and the ECLS materials have come together really nicely as well. But it's a lot of work to create those things, and so we just keep pushing forward. The occupancy rate is very, very high in our ICU, which means just a general level of strain. And this is very common, I think, across BC ICUs, but I think it's always worthwhile to acknowledge the strain that puts each of us under. The strain on the unit, which means the strain on us as individuals and patients. We have a diverse group of patients. The thing I love about VGH ICU is that we get a little bit of everything, HAU as well. The worst thing about it is that we get a little bit of everything, so it feels really great to be the jack of all trades. It does not feel that great to be the master of none, right? So it's always a balance. And that, again, has to do with how we try to support the bedside staff. So it's sort of the best and the worst of things. High complexity means that it's hard to standardize care across patients, and there's constant change, which is a fact of healthcare. Think a little bit about the successes. This is a bunch of nurses getting trained as ECLS specialists. So in the last few years, we've created an ECLS specialist program. This has been long-established practice at Children's, and it's certainly established practice at other sites across Canada and internationally, but it was new to us, and a lot of work has gone into creating a very high-quality education program, which includes a lot of simulation. Simi and the CNEs and M&D, who's the perfusion lead, has spent a lot of time, and a lot of other people have spent a lot of time creating a good product here. This is having an impact across BC and some of the provincial discussions about ECLS. So we're really, really pleased with that. I love simulation. I love doing simulation. I love creating opportunities for other people to do simulation. This is our HAU. So the clinical nurse educator here, she's currently just had her baby, so I'm mat leave now. And me and the second sim lead for VGH, who's Christina, who some of you may know. We've actually incorporated simulation into our HAU orientation, or BTHA orientation, opportunities for at the end of their orientation, after they try to onboard all of the stuff to do with burns, trauma, and high acuity, it's a consolidation day. And it's been very, very popular with our learners. And more simulation. So this is in the ICU. Under the leadership of the CNE team, we have been trying to have weekly sims in the ICU. We're fortunate to have a little sim room, so this is actually adjacent to a classroom in the ICU, and one of these dogs belongs to us, and one of these dogs belongs to the sim program. We've all took training of how to facilitate. We're currently trying to upskill our group to learn how to do more teching with the doll, so that we're not reliant on the sim techs from the sim center, although we love having them, but we don't know how often. So we try to do it on Tuesdays. It's an interdisciplinary sim, so we try to have 2 nurses, 2 RTs, and 2 residents. We don't allow senior physicians to participate, which actually allows the residents to, for the one and only time probably in their training, to practice to be involved in these cases without anybody scary looking over their shoulder. And we focus on principles, regular ICU moments. So it's not about, it could be an ACLS case, it doesn't have to be, it could be a health extubation, something like that. We focus on crisis resource management and communication. And then sometimes we do everything together. We pull them from the bedside. We start recruiting at 8:30 or 9 in the morning. We're saying, okay, what are you doing at 2? Well, I'm going to go to CACCN. So we usually line people up. It takes a lot of effort, but it is worth it. And people, because now that they've been able to participate, they know it's not like evaluative, it's not scary. We're getting people who are more and more motivated to want to participate. So workload does get in the way, absolutely. But usually, I usually have 6 potentials, and 2 people can make it for the nursing. We try to identify 3 or 4 RTs that may or may not be able to make it. And if you approach the attending physician and say, I want 2 of your residents at 2 o'clock, they go, okay. And then they just send them. So, top-down works in some groups and not in others. Sometimes we do all of our favorite things together. So this is the in-situ ECLS simulation that happened in bed 5 in the ICU. So this was, we snuck in the doll and got the Confederates all in, the intensivists were in on this, and one of the perfusionists, and Simi, you can see Simi in the picture. And then snuck in the doll and then hit the code button. And so the fellow that responded sort of walked in, and she's like, oh my God, and then she realized it was a mannequin, and she's like, oh no. But to her credit and to everybody else who's in the room at that time, they simulated an ECMO cannulation, and it was a pile of fun. Everybody bought in. We learned things about our process. That wasn't the intention. It was actually it was intended to be an educational exercise. But, you use what you can. And so we actually learned that, the number was wrong on one of the stickers or something like that. So we definitely identified change in the process. It was really cool. We'd like to do it again, but we don't know when. But yeah, sometimes we like to put all our favorite things together. Other successes, so I've spoken a lot at this group about the wishing well. Essentially, acknowledging the humanism of dying patients, I think, is benefiting all of us, and I think we should do more of it. And it's one of the favorite things I've ever done in my career, and it's spreading wonderfully. And so Sybil has spearheaded it at some of her sites, and we can all learn together how to do it better. So it's pretty great. What am I most proud of? Super corny, my team. This is us. I said that at the outset that we've been trying to celebrate our successes and try to celebrate our people more. Our job is hard enough without, pretending to not acknowledge people. So this is us flipping the leadership team making grilled cheese sandwiches for everybody. We made about, I think it was like almost 200 sandwiches. Because, we had to feed everybody. You can't not give somebody a grilled cheese sandwich, right? So, or a third if they want it. So anyway, we had a good time. This is a CPR challenge. Joel helped us with that. It was also piles of fun. It was so loud we had to close all the doors because there was too much shouting. And then this is the coffee and condolences. So we all get together and send handwritten condolence letters to patients, families of patients who died in the ICU. And that's been spearheaded by our social worker. It's also a nice time to just hang out. This is the team yesterday. I don't know if it was yesterday. God, time flies. We made some pancakes for everybody yesterday morning for Nurses Week. Claudette is not there, but other than that, future Turner, CST. We look forward to that with trepidation. I got this picture from the CST website, and we're really hoping that we look this happy in a few months after implementation. And I would like to publicly thank St. Paul's for going first. Lionsgate for going first. Lionsgate for going first. St. Paul's for going next, and anybody else who wants to get in line ahead of us, thank you. So we have trepidation, we have concerns, and time will continue to roll forward. So and we'll rely on all of you to help us, which you've always already been doing. And the last thing I want to say is about patient and family engagement. I think this is a gap for many areas. It's certainly a gap in our unit, even though we have Wishing Well, even though we do allow patients and families to participate in rounds. We've relaxed our visiting restrictions and that kind of thing. So the culture of family engagement is more, patient and family engagement is more relaxed than when I started, say, in 2005. But I think we still have more work to do. We're still fairly reactive. I think we could be more proactive. And for me, the reason I leave this as our last thought is that the BC CACCN is really showing some leadership in the wanting to investigate what patient and family engagement looks like in critical care. And we're hoping to be able to partner effectively with the council to be able to move this forward. And so we need it at VGH. So we're going to need all of you to help us develop this. I'm quite excited about